all hear me? Thank you. This section is entitled Pharmacotherapy. I have a lot of material here. What I'd like to do is try and go through as many slides as possible and clip them, because as I see, there are a lot of questions, and I structured this such that I could do this. I think I have an hour and a half, and I'm certainly not going to take the full time of slides. What I'd like to do is try and blaze through the slides in about 30, maybe 40 minutes, and then have a significant period for discussion, question and answers, interaction, because I don't know about you, but that's how I learn best, is with discussion. So, without further ado, your learning objectives are outlined. We're going to review pharmacology of methadone, talk about some evidence-based practices and guidelines, and touch this area of what we call risk management for opiate addiction treatment. This is an overview of major topics that we are going to discuss. This issue of patient safety and medication errors is a new initiative, essentially in healthcare, recently recognized since the 90s. But actually, we have to give credit to the Greeks with the Hippocratic Oath. Now, I actually can't remember the precise wording of that oath. I never remember it. But basically what it says is, as a physician, I will prescribe regimens for the good of my patients according to my ability and my judgment, and never to do harm to anyone. Patient safety really revolves around areas of reporting, analysis, prevention of medical errors, and adverse health events. Patient safety initiatives in terms of healthcare have been applied from other areas of business, such as the airline, the automotive industry in terms of quality assurance measures, and etc., using advancing technologies, information systems. There's a need to educate providers and the public, and there are certain economic incentives. As many of you may be aware, Medicare now has taken the position that they will not reimburse hospitals for errors that are made in terms of patient care. If you operate on the wrong limb, you're not going to be reimbursed for that, etc. So you can see this is an important issue in terms of health care. Data on adverse health outcomes has recently evolved, and it's still evolving. I don't know if you're aware of the Institute of Medicine study in 1999, monograph that they wrote in terms of patient safety entitled "To Err is Human, Building a Safer Health System." Much of the focus related to this was directed towards the statistics related to medical errors. It was widely quoted that there are as many as 100,000 errors that could lead to preventable deaths. And more correctly, about 7,000 errors were medication errors. This developed into an interest in terms of patient safety. They advocated for the establishment of a center that revolved around patient safety, developing a reporting system, etc. There's a whole initiative related to this, and there are many organizations in the country that are related to patient safety. So this is a timely topic. In terms of a simple definition of a medical error, I have three here. And the simplest states that a preventable adverse effect of care, whether it is evident or harmful to the patient. Bates quotes an error occurring in the medication use process, and also an adverse drug event is defined as any injury due to medication. Today our focus is on one of the issues related to the human factor. As you can see here, there are many causes related to patient safety and medication errors, there are human causes, medical complexity, systems failures. We're focusing today on the issue of provider experience and training. There are reasons to focus upon methadone in terms of patient safety. As a full agonist, methadone has a certain pharmacokinetic and pharmacodynamic profile. There's variation in this pharmacokinetics and pharmacodynamic profile. There is significant risk related to the induction period. There are drug-drug interactions that bring up issues of safety. And as I'll show you later, there's a trend of a significant increase in the utilization of methadone as a medication. In November of 2006, the FDA issued a public advisory safety. Much of the attention that led up to this was directed towards this trend that we see in overdose deaths related to prescribing of methadone. The National Center for Health Statistics quoted 2 million prescriptions in 2003, and you can see this trend. The data is here. The bottom line is there's a significant trend in overdose deaths related to the drug methadone. Because of that, it warranted what is called a labeling change. The initiative put a black box around certain warnings, and we'll go into detail about this black box warning. Now again, focus was concerned and concentrated related to pain management patients, the pain community, but there was also a advice directed at OTPs, or narcotic treatment programs. I don't know if you recall, but Dr. Clark issued subsequent to that a Dear Colleague letter in December of 2006. A Dear Colleague letter in 2006 that emphasized 3 key points: looking at the initial dose, concentrating on the black box warnings for 4 areas, and also information related to the patient information sheet. Let's talk about these 4 areas in terms of the black box warning: deaths, respiratory depression, complications due to cardiac problems, and use as an analgesic. Just to highlight the information related to cardiac deaths, there's a definite problem related to the initiation and conversion of pain patients with methadone from other opioids. There are cardiac and respiratory problems. There are drug-drug interactions from illicit and illicit use and too rapid titration of methadone, not recognizing this issue of accumulation of the dose. And also warning patients about using CNS depressants, benzodiazepines, alcohol, in a sense of self-medicating that can complicate this issue. Many of the deaths are related to these factors. Respiratory depression is the chief hazard associated with methadone administration, and there's some pharmacokinetics that specifically relate to that. Methadone peaks much later in terms of the respiratory effect, and it lasts longer. This is particularly noted during the induction phase, the startup phase, the buildup. And this can lead to what we call an iatrogenic overdose. In terms of cardiac complications, Dr. McNicholas will go into quite detail about the issue of prolongation of the QT interval and serious arrhythmias, Trusandra points. This has been documented, particularly in the pain community, that we're dealing with pain patients, particularly with these large doses, but it's also been described in patients in normal doses or lower doses, so to speak, in maintenance agonist therapy. And lastly, as a pain medication, it's advised that methadone should be used only when the benefit outweighs the risk in terms of a medication for pain management. Now let's look at some data related to trends in terms of utilization and some limited data that we have on methadone-associated mortality related to Pennsylvania. I was fortunate enough to get some data from ARCOS that reveals, as you can see, this is quarterly data that shows an increasing trend, you can see. Now this is falling off because this report was incomplete. But here's another graph that shows the yearly distribution. As you can see, it's the same trend, a progressive upward trend in terms of utilization or distribution of methadone, total grams, as you can see on the side, liquid, powders, and tablets. Now, here's a yearly distribution in grams as well, but it differentiates it in terms of pharmacies and narcotic treatment programs rather. You can see, if you look at this, it looks relatively stable for the narcotic treatment programs, but there's a definite increased trend related to pharmacies. And the same thing here, this is relatively flat over a period of time for narcotic treatment programs, but there's a trend of an increase here involving pharmacies. Now, unintentional poisonings or deaths. This was the latest map that I could find that pictorially showed you a picture of deaths up until 2004. It's hard to see it in terms of the numbers, but you can see our state relative to some other states such as Florida, North Carolina, Washington, etc. I have a table here later that shows some other states. But again, as Ed pointed out in his slide, you can see there's an increasing trend over the years of unintentional deaths, poisonings due to methadone. And this is another graph that you can see that shows in all ages, and the highest is in this percentage here. Here's this table that I constructed. I took some of the latest data that I could find and looked at the ratio, and just to get a sense of where Pennsylvania ranked in terms of some other the top states where they're experiencing significant overdose deaths. You can see Pennsylvania here. But again, in all the states, there's just this progressive trend over the periods of years from 99 to 2005, the latest reporting period. Here's a report that you should be aware of or have access and read this summary report at the meeting on methadone mortality, a reassessment. Some of the significant recommendations or suggestions in terms of data collection relevant to us was that OTPs began to report data on all patient deaths. It is recognized that this OTPs, or narcotic treatment programs, will require some technical assistance in doing this. But I don't know about you, but I began to organize how I collect my data at the clinics that I'm involved with, and began to get organized to track all patient deaths so that we can, in a detailed fashion, report on the outcome. The other recommendation was that, in terms of dispensing, that there should be some coordination with the prescription management programs. As is stated here, primary care physicians often are not aware that their patients are taking medications, or methadone, and we need to have some process whereby this can be coordinated through a prescription management program. Okay, I want to move now into a fast overview of opioid pharmacology. I just want to comment that you have a variety of resources. The tips in the back, tip number 43, is a very good document. It has, in terms of a text, you couldn't find, I think, a finer document that is referenced, evidence-based, in terms of your supplemental reading as you, go further after today and use as reference material. And we also have a number of resources that are listed on your CD that's in your companion guide. Okay, methadone in terms of its formulation. In the United States, we use what we call a racemic mixture. In other words, it's a mixture of two isomers, the D and the L. And this is just a picture of the chemical structure. Now, much of the comments that I'm making are taken from these two references which you have on your CD. These two articles are excellent in terms of understanding the pharmacokinetics of methadone. Shen Epps' article is an excellent monograph, and the article from Ken Wolf is also included. And I'd ask each of you to review these articles. Now, pharmacokinetics, what are we talking about? For the non-physicians in the audience here, we're talking about how the organism or the body handles the drug. We're talking about absorption, distribution, binding in tissues, biotransformation, metabolism, and the excretion of that drug. Now, methadone, in terms of its absorption and distribution, it is a liposoluble, meaning fat-loving drug. It's detected in blood, in the bloodstream within 15 to 45 minutes after oral administration. It's rapidly distributed to the tissues that are listed here, and it has what we call a large volume of distribution. It has a long half-life, as well as what we call a slower absorption compared to other opioids. And there's slowing of gastric emptying. The absorption is not related to the stereoselectivity of R versus S. They're both absorbed. Now here's a graph that shows this. Fortunate enough to get this from Chuck and Teresi. This long elimination phase and this large volume of distribution. And as you can see here at what we would call our trough level, etc., you can see this distribution, it peaks and it comes down very, very slowly. The peak plasma concentration for most patients takes place 2 to 2.5 to maybe 4 hours, but there is some individual variation. And there's also been noted a second peak plasma concentration that can take place about 4 hours after administration, and it may be detected due to what we call the enterohepatic circulation of the gut and the liver. Now, many of you probably have patients who say there's a difference in the tablet versus the liquid. But from studies, pharmacokinetic studies, absorption rates, according to the test, are the same for the tablets versus the solution, but try and convince your patients of that. And this just quotes a study that basically says the same thing. In terms of the bioavailability, in terms of the prototype drug morphine, you can see that there's a difference in the bioavailability, meaning that it's very high for methadone, about 80%, as opposed to a much lower rate for morphine, about 30%, and then you can see the difference in the half-lives for the two drugs. Now, there can be some inter-subject variation in this bioavailability, but overall, it is still good, about 70 to 80%. Now, plasma, it's important to remember that the plasma concentrations are maintained by the tissue reservoir, and it's the unbound fraction that really is the action that, or the fraction that causes the action or causes the effects of the pharmacodynamic effects of the medication. And it's a smaller fraction, as you can see here. It's only about 12%. And there can be some variability in that rate. Now, in terms of proteins and tissue binding, Methadone is highly bound to a variety of plasma proteins, albumin in particular, lipoproteins, but also the alpha-1 acid glycoprotein. And it appears that the R isomer has a lower proportion of binding, and as you can see, if that's the case, then it has a higher free fraction for action. Now, in terms of protein binding and tissue binding, changes in binding to methadone and to plasma proteins can have an effect or alter the total clearance, the hepatic clearance of methadone. And again, this is related, can be related to the alpha-1 acid glycoprotein. There is what we call genetic polymorphism in terms of variation that can explain why patients can respond differently. Now, moving on to biotransformation, methadone is broken down or biotransformed into a variety of metabolites. EDDP is the principal one, and this just shows the structure. So following the biotransformation, it's excreted through the kidneys and in the feces, and the principal enzymes involved are what we call the cytochrome P450. CYP3A4 is one of the main enzymes. But it's important to note that there are about 9 different metabolites that have been identified in the urine and also the feces. But the main one, and many of you have laboratories that report the metabolite in the drug screens, EDDP, and that's what they're reporting. Now let's look at some factors related to age, renal or kidney function, hepatic or liver disease. Methadone, according to Shin et, does not appear to be markedly affected by age. Over 65 years, there's a slight decrease was noted, but nothing major. There is some issue with renal function, but not a lot. Now, data is limited according to some authors, but they recommend that for patients with what we call end-stage renal disease, that their dose be reduced. I don't know how you manage your patients who are on hemodialysis and sacral care hemodialysis, but in my experience, I haven't had a lot of problems with patients who are on dialysis. Liver disease. He quotes a study in this monograph about 11 patients with severe alcoholic liver disease, and there was no evidence of any problems with patients in terms of methadone dosing, but we should note that there is a longer half-life and a higher volume of distribution. The oral clearance for the medication for methadone in these patients was found to be similar. So it is suggested, but not confirmed, that in stable patients, they can maintain a methadone dose without any particular problem. There are 2 studies that have suggested, however, that, and it's been my experience anecdotal as well, and maybe I'm just reading into it, that patients with hepatitis C require somewhat higher doses than patients who do not have hepatitis C, but again, this has not been studied well. So again, in summary, in terms of age, renal, hepatic disease, and the pharmacokinetics, clinical experience would really dictate how you manage and monitor your patients. You should be cautious in terms of induction and also in terms of how you prescribe your dose of methadone. Again, this is more just to say that it has not been, in terms of liver disease, well evaluated, and there may be some risk in these patients of toxicity related to accumulating doses after multiple dosing. This is taken from the package insert for methadone or dolafine. Now, let's talk about the enzymes, and again, I believe Dr. McNicholas and I will go into detail about the cytochrome P450 enzymes and drug interactions in certain medications, but from a primer point of view and an overview, you should be aware that there are many of these enzymes, and it's a family of genes, but the major isoforms, as you can see, are highlighted in yellow, 3A4 and 2D6. But there are at least 5 or 6 that are involved in the metabolism of methadone. And what we're talking about, there are certain ones that induce these enzymes, meaning they lower the methadone serum level and precipitate withdrawal, or they inhibit and they can cause or raise the level to the effect that there's an increase in the effect of methadone. There's genetic and environmental factors, however, that lead to some variation. Now, this is just to remind you that we will have an extensive overview of drug-drug interactions in Part 2. Let's talk about the pharmacodynamics. Here we're talking about the effect of the drug. We're talking about drug concentration and the effect. You should be aware that there are principal opioid receptors, and the one that we most commonly talk about is the mu opioid receptor, which is the top one. Methadone is a full agonist, meaning it fully occupies the mu receptor. It binds and activates that receptor, and increasing amounts cause increasing receptor-specific effects, such as analgesia, respiratory depression, sedation, and it can cause death. Borrowed slide of Dr. Nicholas is here. Everybody's probably seen this slide over and over again. But it just depicts and shows you the difference between a partial agonist, and she's going to give you a good overview of buprenorphine, as opposed to the full agonist. And you can see, this is what we mean by a full agonist, and the effects can go up, 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 till you can get overdose or death. With buprenorphine, the difference is you can only go up but so high. Now, in terms of our issue today in patient safety, we need to recognize that there is some inter-individual variability. That's what Chenep's paper is about, this focus on inter-individual variability related to the cytochrome P450 enzymes, genetic factors, environmental factors, and also the possibility that the glycoproteins have something to do with this. There are several possible mechanisms also. As you know, methadone has several mechanisms of action that can cause. This can be related to individual variation. Again, saying about polymorphism and this issue of receptors. But despite this, despite the variation, I think the take-home message is that we do have a good relationship between dose and pharmacologic plasma concentrations within the individual. Now, I show this slide here because when I first saw this about 4 years ago at a conference, a pain management conference, when I saw this, this really was a take-home for me because I couldn't figure out why certain patients could tolerate a dosing schedule that I, commonly used for many patients and others couldn't. And if you look at this, this is actually a study that they did with pain patients. And what it shows is this thing that we're talking about, the variation. You cannot look at a patient, you can't get a history from a patient and know how they're going to respond. But when I saw this and talked to Dr. Andrees, he said this is correct. That what this shows is the variation and the way people respond. One patient may have this profile and another may have that. And you can't tell when you start a patient how they're going to respond. This is why some patients will say it's not enough, And others will come in and say, oh, it's far too much. So that's why I'm showing this slide. And also in Wolf's paper, he shows the same thing. If you look at this, this is the evidence of, you can look at this in terms of the peak period, and you can see, now, unfortunately, the way this was done, the dots are all black, so you can't discern one line from the other. But this is about 17 patients, and you can see the difference in the various levels here in the peak period. And if you go over here to the trough, you can see there's variation. So again, to me, this was a take-home message in that you just don't know, and you can't get it by their history. Okay, let's briefly talk about evidence-based guidelines. You have a table here that I sort of borrowed from Stu Leverett, modified it, and put in some more current guidelines. As you can see, we have our guidelines from the U.S. Registry 2001. TIP 43 is considered guidelines. The FDA advisory guidelines were issued in 2006. ATOD has recently adopted guidelines that you can, for induction, that you can review on their website. Both ASAM and CSAM, which is California, ASAM are in the progress of adopting guidelines and probably will have them published within the next month or so. But you can see how we compare with various countries, United Kingdom, Europe, etc., and a number of countries, or number of other areas like Canada. Yeah, I think that's it, pretty much it. But for the most part, you can see there's a commonality in terms of what the first dose should be, and we'll go into in-depth detail about that later. But you can see it's pretty much a starting dose of 10 to 30, and in some cases 10 to 20 with a maximum. I didn't see one indication here where the maximum dose for the first day should be 40 milligrams or more. Now, in terms of stages of pharmacotherapy, we recognize induction, stabilization, and maintenance. Let's talk about induction. Okay. First, you should really look at what are the contraindications. Does the patient meet DMS-4 criteria? They must have a 1-year history. Are they able to attend the program as required? Remember, this is ambulatory treatment. Can they come to a clinic daily? Is there any history of an allergic reaction to the medication? Do they have any cardiac history or complications? And are there serious problems, as many of you have discussed, with alcohol and sedative hypnotics, benzodiazepines? In terms of the initial dose and induction, it must be given under supervision. You can't give an order and the patient take it later. You must supervise that first dose. There should be no signs of sedation or intoxication. And the patient must manifest withdrawal. Now, the guidelines, basically, the consensus is that the single dose of 20 to 30 for the first dose is advised, but it can be less. And it should not exceed 30. You can provide same-day adjustments, but you need to evaluate your patient 2 to 4 hours after that first dose. That's the peak period. And it may be advisable to give 5 to 10 milligrams. And again, the maximum dose for the first day is 40 milligrams. Now, adjustments during the first week. What we need to be aware of is the accumulation. Now, many of us have what we call, not necessarily standing orders, but we have protocols. We'll start a patient on a dose and we're right for the next dose. We're going to talk about that subsequently. We need to keep in mind also with patients of incomplete tolerance and loss of tolerance, that more directed at patients who've had a prior history, but I'll come back to that as well. Safety is the key issue. Again, there should be no signs of intoxication or sedation, and it is helpful to have some kind of objective scale. I don't know if you use something like the clinical opiate withdrawal scale, what we commonly call the COW score. Many of you are familiar with that. There are other instruments, but you may have your own. The physical assessment should rule out any life-threatening conditions. We should also screen very carefully for substance use that may be contraindicated in terms of the patient being admitted. You may have someone who's so severely dependent on benzodiazepines that it might be advisable that this patient go through an inpatient detoxification and then simultaneously placed on methadone or etc. And if you have the capability, you really should observe the patient 30 to 60 minutes after that dose. Many of you have heard this expression, start low and go slow. And this is what I commonly tell patients, because they'll look at you and they'll want 80 milligrams on the first day. And you said, no, I'm going to give you 20, 25, or 30, and we're going to go slow. And they look at, oh boy, they're crazy. So again, start low and go slow. It's important to recognize the steady state or the buildup. What we're talking about here is that it takes multiples of the drug in terms of the half-life. It takes 4 to 5 half-lives to establish a steady state. And in most patients, it may take 5 to 7 days. Some patients may reach steady state sooner. But this is what the research states, that it takes 5 to 7.5 days. Many of you have seen this slide from Dr. Pate. I give him credit for this. And what this shows is what it takes. I have this in my office, and I show it to patients when I induct them. The reason why they're not getting 80 milligrams is that it takes time for this dose to accumulate. And you can see it takes 5 half-lives to get to this steady state. Now, in terms of that first week, when you interview your patients, we often ask them, well, how are you feeling? You really should be asking the patient how they feel during the peak period and not the trough period. In other words, how do you feel 2 to 4 hours after dosing? And not, well, how do you feel just before you come to the clinic? Again, you're not taking into account the buildup. Because what you need to emphasize to the patient during that first few days or weeks of treatment is you need more time to reach steady state. Again, this is a table that I borrowed. It shows the phases and pretty much, what I've been saying in terms of initial dose, early induction, late induction, and maintenance. And again, we're talking about the time to establish their tolerance in the early. That's what you want to see. You want the patient to demonstrate their tolerance. And you cannot get that on the first day of treatment. You don't know what their tolerance is on that day. Patients are 6.7 times more likely to die during induction than untreated heroin addiction. This is a study done by Cable Horn in Australia, and it is true. At the same token, 42% of drug-related deaths occurred during the first week of treatment. Again, another study. And lastly, another one that said that 10 deaths reported were all within less than 7 days of treatment. So the induction period is a very potentially serious period that should have appropriate decisions made in terms of dosing and monitoring of patients. Now, here's a table that I constructed only for educational purposes, just to compare, based on the principle that 50% of the dose remains. So if you look at this table, and we look at the first induction schedule of 30-30, what this says is that even though you're only, and it's again, remember that spiraling slide, what I'm talking about here is the effect. The 50% of the dose added each day. By the 6th day, you have the effect of 60 milligrams that the patient is getting. So you can see the potential danger if some of these schedules may be familiar to some of us in the room in terms of writing orders. But if you look at this, 30, 40, 50, 60, 70, this is the effect that that patient will have on day 6. They're getting 80. So again, you have this, and these slides, I understand, will be on the website, so if you want to use this information. Now, I'd like to go into a couple of cases. George B. George is a 37-year-old guy, had opioid dependence, heroin since age 27, cocaine since 21, and alcohol. Very typical patient, I want to say. At intake, he reported daily heroin for at least 3 years, consistently, varying amounts based on how much money he had. He denied any cocaine use at the time. His admission, drug screen, and on intake was positive only for opioids. Okay? The only other significant factor in his history is he had a history of hepatitis B and C. Okay, here was his dosing schedule. Upon review of the records, there was no CAL available, but the physician documented that there was physiologic dependence. In other words, he met all the guidelines and criteria to come into methadone. So, orders were written. There was, in the chart, no record of follow-up. However, as stated here, on the 22nd, the patient's father called.
Can't hear.
I'm sorry. Oh, mic's not on? There. Oh, it's right here. Hello, hello.
Battery's probably down, Mike.
Oh, is that battery? Thank you. Thanks.
Start that slide
Can
on.
you hear me now? No?
Good try.
Can you hear me now? Can you hear me now? As stated here, on the 22nd, his father called and advised that the clinic the patient had died. Stated that he was found on the sofa, could not be revived, and by the time they called 911, it was just too late. And the father said, his funeral's today at 1 o'clock. So, again, I go back to that slide, 30, 40, 50, 60, 70, 80. You've got 80 milligrams on that, the 17th, I forget, which was, I can't remember, Saturday. No, it wasn't a Saturday, it was, let's see, a Tuesday, that's right. And that was the last dose. Let's go back to the history. There was no benzos here to blame, okay? No alcohol, no cocaine. And this was someone, I believe, that had had prior history of methadone, so it wasn't necessarily, this was his first methadone program. So that's George B. Let's go on to Barbara B. Not Barbara and George Bush, by the way. 26-year-old, opiate addiction, 3 to 4 years, heroin, but also prescription opioids. At intake, she admitted to using heroin at least 3 bags a day by injection. She really preferred pills, and she couldn't get pills anymore, and she would take at least 2 or 3 Percocets in the early morning. The exam demonstrated physiologic withdrawal, signs and symptoms. Her CAL was 21, which is about moderate. And urine drug screen, again, positive only for opiates. History of hepatitis, major depression, and post-traumatic stress. Here's Barbara's dosing schedule. However, the difference here is, like I said, day 1, CAL was 21. Physician wrote an order for 30. Wrote an order for 50 for day 8. On the second day, on 8/8. And actually saw the patient. Asked them, how are you doing? Well, it's holding me for about 18 hours, but I'm restless, I can't sleep, I have nausea in the morning, sweats, my pupils are dilated. Left the order 50 for the 9th. Saw her again on the 10th. Now was holding about 22 hours. She appeared visibly ill to the physician, clammy, pupils were dilated, decided to raise the dose to 70. She got 70 on the 11th. I believe it was around 10 a.m. in the morning. went home, said that she fell asleep on the sofa. She was playing with a little boy or something, and her family found her unresponsive. Called 911, and as is stated here, she ended up in the ICU, Narcan, and they discharged her subsequently after starting her on methadone again, but up to a dose of 40. So we have one that didn't make it and one that did. But you can see again, going against the principle, going against the principle, 30, 50, 70, 70. Again, it didn't recognize the accumulating effects of that. So I just wanted to share with you these two cases. Now, stabilization. Here we're talking about steady state is when a treatment medication is eliminated from the blood, etc. Stabilization is achieved when the patient no longer exhibits withdrawal, drug-seeking behavior, etc. So in other words, we try and stabilize our patients in treatment, but steady state is a different phenomenon. Let's talk about the desired response of methadone treatment in terms of stabilization, where our goals are. We want to prevent withdrawal. We're trying to eliminate drug hunger and craving, and to establish what we call blocking euphoria. Many of the patients will say, I want to be on a blocking dose. Now, what is the optimal dose? As was pointed out here, research has time and time demonstrated that the effective dosage range is between 60 and 100. It can vary. And outcomes are better in terms of retention, opioid use, and craving compared to much lower doses. You look at some other studies that have been well established, the higher the dose, the lower the risk of leaving treatment. But we have this public health problem here that there's a philosophy, and I think it's not quite as rampant as it was in the past, that the dose should be as low. We're the low-dose clinic. In terms, that's something to be proud of. And doses are not prescribed in many clinics according to what they're really supposed to, and it's based on philosophy, etc. I mean, there's a moral issue that, you shouldn't be as too much methadone. So clinics should really look at their dosing policies and recognize that you're going to prescribe methadone according to a medical indication like you would prescribe any other medication based on a patient's demonstrated need. Yes, we need to be cautious, but we should not have this philosophy of a certain dose level. And tip 43 says it all. The consensus panel recommends that methadone dosage or maintenance dose of methadone not be predetermined or limited by policy, and that the policy should allow for adjustments for the individual. Again, more about the optimal dose. Okay, and again, Tom talks about this very nicely. I keep saying Tom, it's like you all know Tom. Dr. Pate, sorry. Everybody knows Dr. Pate. Is a friend and colleague of both Laura and I, and many in the room. And Tom has a series of slides about what is the optimal dose. And he doesn't believe, as we do, in this terminology of a high dose or a low dose. It's an optimal dose, and that the patient is responding appropriately. Let's talk about some common dosing issues. We're talking about serum, methadone levels, or therapeutic monitoring. This is a study that's been quoted that shows that there's little correlation between the mood and the dose level, and the non-holders and the holders. But what there was correlation was with the rate of change of the peak to trough level. Serum methadone levels do not indicate the adequacy of a dose. Many of you might use that say, oh, their doses this should be. You cannot use a methadone plasma level, blood level, or serum level to say that the dose is adequate. And it does not predict toxicity. It can be used in terms of the ratio in a therapeutic sense to look at the dosing interval to optimize the therapy. But you have to look at the clinical picture, and there's some incongruity in terms of doses. Also, it can be helpful when you're using certain medications that can cause drug-drug interactions. Many of the antiretroviral drugs interfere, and doing therapeutic drug monitoring can help you make a decision about a patient's dose. And it can also help you in terms of looking at doses that some might feel are not justified. And also looking at divided doses. Typically in a treatment program, we may split the dose, but beyond that, 2 doses. I'm not aware of any program that splits it beyond 2 doses or 3 doses. The interpretation of serum methadone levels, again, the take-home message here is, you cannot use a level to treat a patient, just as in medicine, we don't use a test 100% to treat a patient. The patient comes into the emergency room with crushing chest pain, and you do an EKG and you say, hey, I'm sorry, you're not having an EKG. It's perfectly normal. No, you treat that patient clinically. So again, I'm borrowing a slide here from my colleague, Dr. Pate, and his message is, dosages are determined clinically. And although he advocates using serum methadone levels, but don't get bent out of shape about using them. It's the peak, and we'll talk about this later when we talk about drug-drug interactions, if you're going to use that. When you do a peak and trough test, a ratio that is very suggestive of giving a patient a divided dose if they have a very high peak to trough ratio. That's pointed here. 800 is over 200, and the ratio is 4. I did one last week for one of our patients, and the peak to trough ratio was 1.23. And that helped this patient to see that, your levels are consistent. You're not really showing the symptoms, and she agreed as well. Again, just more of the same message, that although there is a linear relationship, you must follow the patient. And this is work that was done by Wolf in '99 to show a linear relationship, but it's not exactly 100%. And you cannot correlate a clinical response with this linear relationship. I want to go back to this one because many have used this 400 nanogram per ml level as saying it's adequate. But again, you need, as F points out here in his research, there's been no study of that. And it hasn't been demonstrated. It hasn't been validated. And just saying here that you don't have to do them for all patients, obviously, but there are certain situations. So, again, use your judgment pretty much in terms of therapeutic drug monitoring. Now let's talk about split dosing. Here's a very common scenario, particularly with certain patients who are on antiretroviral therapy sometimes, and then patients who are pregnant. And the goal here is to split the dose such that this is the split here, you can see, you smooth out their dose response during this period by splitting the dose. You avoid them getting too high, and they avoid feeling sick, so if their dose is split. But, it's controversial in terms of a patient being stable enough, to have a split dose. I remember very vividly giving split doses to one of my pregnant patients, and we had to take the split dose because we found out she was selling the split and using cocaine. It's a hard decision, to make. So you really have to evaluate the risk benefit and is the patient responsible. Contingency contracting. What we're talking about is behavioral agreements, contracting. The consensus, I'm going back to tip 43 because they have some excellent recommendations on contingency contracting. And the recommendation here is that any manipulation of a dose as either positive or negative as a consequence of behavior is inappropriate and has no place in medication-assisted treatment. In other words, you shouldn't hold a patient's dose or raise the patient's dose, etc. Now, that doesn't mean that you may not hold a patient's dose if they're intoxicated, etc. So I'm not talking about that. I'm talking about a contingent behavior, and then you reward or you punish a patient based on that. Okay. The only, as they point out here, relevant consideration is in the area of take-home medications. Again, it's controversial. Some well-written studies about using contingency contracting. Maxine Stitzer is well known for her research in this area, and I encourage you to read about that. Over-medication, nodding, everybody knows this. Inappropriate nodding or falling asleep or being loaded. Newer patients may describe this as nausea, scratching your face, the nose, and so forth. And in some, the sedation may be unapparent. And in many patients, they have a fear of this because it's a reminder of the intoxication, and it's frightening and potentially can trigger a relapse. We'll talk about how many of you manage over-medication. Vomited doses. You should have a protocol or consensus on how you manage patients who vomit. This is taken from tip 43. If emesis is greater than 30 minutes, you can reassure that patient that they may not, more than likely, have any problems. 15 to 30 minutes, 50%, and then less than 15. It's safe to give that patient their full dose. What do you do when a patient doesn't come every day? They miss days. 1 to 2 missed days. In other words, less than 3 consecutive days absence from the clinic. Many programs will give that same dose to the patient. 3 to 5 days or greater than 3 consecutive days. There's variation and reduction, etc. Maybe a whole process. And then I think a bigger problem that I see is a recurrent pattern of irregular attendance. And the only way that you can really look at that is if you, as a physician or somebody in your program, regularly looks at dosing schedules to see who's coming one day and getting dosed 2 days in a row, they're skipping. Because, they'll know, in our program, you miss 3 consecutive days, you got to see the doctor. They don't want to see the doctor. So they'll skip in and around, and you look at this pattern, and we have an automated or an electronic record, and I can pull up a report, a missed dosing report for a period, like a month or 6 weeks or whatnot, and I can see and count the number of days. And those, in my opinion, require case consultation to address their serious non-adherence with attendance, and you might need to take other measures like, stepping up the level of care, etc. Take home, so the controversial topic of all methadone programs. I want to draw your attention to the federal regulations and the Pennsylvania State Chapter Regulation 715.16, the Code of Regulations. As a reference, we must follow these guidelines. And also, many of you are aware of your colleague letter from Dr. Clark, January 8th, talking about a statement on the policy of clinics being closed for business on Sundays and holidays, and many programs are taking measures to address this issue. Now, from our standpoint, you should recognize that take-homes, as in the language of the state and federal regulations, are the responsibility of the medical director. The medical director assumes responsibility for the decision regarding take-homes. Programs really need to address how they do this. Now, in terms of exceptions, there are certain conditions, both state and federal, for which you can request an exception for an unusual hardship, a medical condition, etc., and their procedures, and you must follow these procedures. Now, in terms of the routine protocol, as you know, our routine take-home policy differs from the federal in terms of the time and the quantity of take-homes that are permitted. Again, I say it's controversial, and it can be a point of contention in many programs. The biggest issue I think we struggle with is really determining if this patient is stable and responsible. Basically what you're saying is that this patient can take the medication in an unsupervised fashion. It's okay to decrease their clinic attendance. But in many cases, you really need to look, what's the specific rationale for the take-home medication? Is there potential for rehabilitation, such as employment, child care, caregiver responsibilities, important endeavors, etc.? And then also, you know, many of you, like me, have worked in this field for many years, and you need to review those regulations or those requirements for the patients. They'll be on take-homes, and you know, you need to look at the conditions. Are they still working? Because in many cases, I found out, oh yeah, they had a job, but they hadn't worked in 3 years, and the original reason was they had a job. So you need to look at that. You know, in terms of drug testing, supervised withdrawal, voluntary taking. I want to detail. I want to get off this. We've all heard that. You know, again, based on the recommendations of Tip 43, you should carefully review this decision. What is the likelihood of success? It depends. It's an individual factor related to motivation, their support systems, their physical and psychological well-being. You know, patients, you know, have the attitude that just want to keep me on this stuff, or y'all just want to make money. And we're trying to explain to them that's not the case. We want them to consider possibly tapering or weaning when it really is likelihood that they'll be successful. One of my programs, we use an instrument that they've developed called When to Taper. And basically, you know, it looks at a variety of factors, and the patient and the counselor meet along with the doctor and then review this documentation. And we come to a consensus on, is this a good time to begin? Are you really stable? You know, because I think one of the biggest challenges that we had with patients in methadone treatment in particular is retention. Most patients don't stay in treatment long enough, in my opinion. So again, they'll want to come off, in my opinion, too soon. But there's a way to go about it. That's what I'm talking about in terms of many patients have not demonstrated an adequate therapeutic trial or demonstrated an adequate length of stay in treatment and are not stable. Now, it should be an informed consent process. The patient should be aware of relapse prevention strategies. I advocate, and we all advocate, participation in self-help meetings. And then when you do begin a taper, there are guidelines. And I tell the patient, you know, this is the easy part, concentrating on the taper. Let's concentrate on the hard part. But in terms of guidelines, it's recommended 5 to 10% of the dose every 1 to 2 weeks. Most patients can tolerate this regardless of their dose, but many patients begin to become symptomatic when they get around 40 or 20, etc. Again, drug screen monitoring to see if there's relapse. There's opinion on whether you should even begin this with somebody who's opiate negative, but benzo positive, or marijuana positive. Again, AMA. What I'm talking about here is if you can't come to a consensus that the patient needs to remain in treatment and they haven't successfully completed their goals therapeutically, that it's advised that they can leave treatment, but it's really against medical or facility advice. Many patients want to, I shouldn't say many, but some patients want a blind detox. I don't know how you feel about that, but I've done a few, and I personally don't think they're all that helpful. Maybe that's just my opinion, but it's kind of difficult in our system anyway, because when the patient gets their dose, they sign for it, and the dose is there. So, you know, some people like to do a blind detox. Involuntary discharge is the really big problem. When you come to a situation where a patient has to be discharged involuntarily, you should keep in mind that it should be in the best interest of the patient and also in terms of the safety of the program. You must keep in mind the Chapter 715 regulations and having a policy and procedure for this, and failure to retain a patient in treatment despite all efforts. There are specific conditions which they enumerate here in which this is permitted, and there should be a minimum of 7 days to taper a patient, except if there is a violent act or physical violence. Again, we're focusing on the specific conditions: non-adherence with clinic attendance, intoxication, where there's danger to the patient to be continued on methadone, and there has been consistent failure to progress in treatment despite all efforts, and even putting this patient at a higher level of care. What we try and do at all costs is to transfer that patient to another program, to give them an opportunity in another setting. Sometimes they do better. Just some last comments about touching on the subject of risk management. It's a new area for opioid treatment programs. We touched on it briefly about liability and legal issues. The big focus now is deaths related to overdosing on methadone. And again, I know much of the attention has been related to the pain community, but we as methadone providers or people who work in methadone treatment have to look at this issue from our own perspective and not saying it's mostly the patients in the pain community. There's some recommendations relating to dosing and monitoring, etc., that are new, and there's also some issues that was pointed out involving impaired driving and driving concerns related to patients on methadone. So this is new territory that we're entering. It's recognized that there's going to be a need for staff training, that there needs to be policies and procedures. Guidelines and standards are going to be referred to as the standard of care and duty of care in any area of litigation. So it's important to recognize and to follow guidelines, or at least to be knowledgeable about what the standards are and what the guidelines are. We need to do a better job in terms of informing patients and having patient education. This has also been shown to minimize the risks in terms of adverse consequences of medication errors and issues of patient safety. And that's all, folks.
We have time for about 10 minutes of questions, so if there are any questions for Dr. Taylor.
And we'll have questions during the lunch.
We're going to have a little bit of discussion during lunch, but let's concentrate on this lecture now.
Yes, I wanted to make a comment that, of course, I agree that there is no such thing as high dose of methadone and low dose of methadone. That's one thing. That is the proper dose of methadone. But surprisingly enough, well, not surprisingly really, is that people who do not use other substances, such as benzodiazepines or cocaine, are mostly helped by the doses of methadone between 60 and 100 milligrams a day. Very rarely do they need the doses more than that, or sometimes they need the doses less than that. And of course, if they are clean from, negative for other substances on the urine drug screens, then the doses other than that can be utilized. But when we have a situation that about 80% of the clinic patients in some clinics are not negative for other substances, then I think that we need to draw a line and say that for the purposes of patient safety, we cannot just give them methadone doses higher than those average doses. And I encounter this situation in my practice very often. And when the people, let's say, when the patients take benzodiazepines and or cocaine, and they ask for higher doses, what I usually tell them is this: that majority of patients are held by the doses of 60 to 100 milligrams, 120 at the most. And of course, you may need higher doses, but in order to determine that, I would need for you to stop taking other drugs. Because otherwise, there is no way for us to determine whether or not they need higher doses of methadone. And I think that from the medical legal standpoint of view, this is also the most, what you call it, justifiable position. And this is...
Okay, I gather that that was a comment, and again, I support abstinence from other drugs, and again, I support the action of emphasizing to the patient that you say your dose isn't holding, but look at the issue here. You're using benzos, you're using cocaine, marijuana, and we educate our patients, and there's an excellent ATF brochure that talks about the interference of other drugs in stabilizing the patient. But by the same token, I think we should recognize that although there's an average dose range, doses should be individualized because there's genetics, there's other medications, etc. So I support what you're saying, but I don't necessarily prescribe or tell a patient that the average dose is 120 or 40 milligrams and we should be doing well. I point out to them that, these are factors that are limiting our ability to adjust your dose.
Yeah, just to comment on both those responses. And because I agree with Dr. Taylor that there is I don't believe in average doses. I mean, you can go through the numbers and come up with an average dose, but I'm not sure what it gives you other than what most of your patients are responding to. One thing that I do want to point out, and it's a section of Dr. Pate's lectures that Dr. Taylor didn't have a chance to go over today, and that is, why is your patient asking for an increase? And is it because they are physiologically uncomfortable, because they are craving, or because they want something from methadone that we would actually prefer that they not get, which is the feeling of sedation and the feeling of getting high on it. And there are some patients who, okay, if you tell me I can't use heroin, I'm going to use something so that I feel it. And we have to educate our patients as to what the effect of the methadone is that we want them to get, and that is to be stable, to not be in withdrawal, and to not be craving. And so I think that we have to look at what dose is appropriate for each patient, but realize where the patient may be coming from and what kind of supports they need in managing those issues.
With regard to your graph of, I think it was Dr. Pate, which showed the variation in doses all over the place, and not just going up, but it was not Dr. Pate, it was actually the other on page 22, where I guess the levels were all over the place. Did those patients have other drugs on board?
No.
Or two patients?
The one study was, I believe, 8 cancer patients, and the other 17, control. There were no other drugs.
Okay, so then they were on chemotherapy, and the possibility of drug interactions, or at least serum level changes because of their chemotherapy, which caused that. But the reason I'm asking that is because, we see a fair number of patients who are on antiretrovirals, but some of them are also using the illicit substances, cocaine, marijuana, and so, we get that same problem where we can't really judge what their stabilization dose is.
Right. The first graph was not with cancer patients, not substance, but pain management patients with methadone. The second was opiate, 17 opiate. Healthy, no other drugs. So you can't say that it was the other drugs or etc. The genetic variation, that was what he was trying to show.
Dr. Taylor, the basis of all that you said and all the variations of going on and coming off methadone, what justification is there for any program to say to a client, I'm not dosing you today because you can't pay?
You can't pay?
You can't pay for your dose.
There is, in my opinion, say, when you're talking about detox or whatever, in some cases, detox.
Personally, I think it's
unethical
to take that position. You must work out some kind of an arrangement with
You must work out some kind of an arrangement with the patient for their responsibility for their care, just as anything. But to just suddenly cut a patient off and say, you're not being dosed today, I think is unethical.
Dr. Taylor, I'll ask a question. Actually, I'm speaking at many hats, but I'll speak as an internist here. And I'll ask you, but also the whole audience. As we heard in the last lecture and even prior, that methadone deaths are mainly, or we think are mainly due to non-addiction specialists prescribing methadone. And we heard earlier today, too, that there was some lack of communication between addiction specialists and especially methadone facilities and primary care who might be prescribing this methadone. I wonder if there's any role for methadone facilities to teach their local providers who are prescribing methadone at 240 milligrams a day for pain about appropriate prescriptions and the pharmacokinetics of methadone. Is there a role for methadone facilities to teach the rest of the field or the rest of physicians about methadone and its pharmacokinetic properties?
Well, yes, to a certain extent. However, from my experience, when methadone is used primarily in the pain community or for pain patients, typically, although their dosages may be high, more than likely they're in divided doses, 3-4 times a day. Whereas in an opiate treatment or narcotic treatment program, unless the patient is on a split dose, we typically give a single dose. But, me personally, I'm always open to collaborate with any of the providers in the pain community.
Yeah, I'll just mention, I think as an internist, I'm an addiction provider as well, but as an internist, we don't know this stuff at all. I'll be very cavalier. Many primary care doctors are starting people on 40 milligrams of methadone 3 times a day for pain. And it's just not out there. We have not learned, and you know this in your medical school training or health professional training, there's very little education about how to adequately treat pain.
I'd encourage you, and part 2, when Dr. Nicholas and I do comorbidities, I'm doing a brief segment on pain. But part of what I want to emphasize too, and I have some cards here, there's an excellent opportunity, because a lot of what I've learned about pain management, methadone, comes from going to conferences related to pain. In Philadelphia, in November, there's the International Chemical Dependence and Pain Management Conference. You'll see cards around. I'd encourage all of you to save that day to attend it. That is an excellent, this is I think the 7th or 6th annual meeting, and it's an excellent opportunity to network, to learn about pain management methods.
One more question.
Yeah, this is kind of a common question, but we do have, and you bring it up, with patients, many patients who are opiate dependent in the sense of the heroin addict, heroin addicted person, and they're chronic pain patients at the same time. And one of the things you can do within a narcotic addiction treatment program, as long as they're opiate dependent, for DSM or TR opiate dependent, you can bring them in, put them on methadone, and then they have the issue of the pain. One of the things you are committed to do, obviously, is split the dose, let's say half and half. Okay, does that give you sufficient coverage in terms of even twice a day, or would you have to give it 3 times a day with like a third in the morning when they come in, and then 2/3 for a take-home at home to give them the actual pain management as well as having them in a methadone program?
Now, from my experience in talking with what I call the pundits in the pain management field is no, patients need 3 times or 4 times a day dosing for pain.
The analgesic.
On the analgesic, right. So that's why it's problematic or difficult to do that in an opiate treatment program.
Thank you, Dr. Taylor. That was